spleen, right? So now let's do the exact opposite thing. Again, your probe right now is located very close to the head of the patient, right? So as you are evaluating the pancreas, we are going to slowly push in, and we are turning in the opposite direction like this. Okay, those two blood vessels. So hold on one second. So isko na chhod do. You are pressing too much on the pancreas, and the pancreas will not enjoy that. So here you are, you're keeping those blood vessels on the right side of you. Okay, so you're seeing that the meat of the pancreas is underneath. You see a nice interface right under it. So you've got a very good view of the pancreas. Now we need to figure out how to go to the neck. The neck of the pancreas is closer to the patient's legs, and so you need to push in ever so little to get there, right there. So beautiful. That is the confluence of the portal vein right over there. It's where it's breaking up. That little dot is the pancreatic duct that is falling. Okay? So this. Again, so you're doing a great job in being able to do this whole thing by simply moving your left hand. You are not moving your right hand except to move the scope in or out. Okay? So we'll do that again together. You're coming up towards the tail of the pancreas, going to the left, big knob down, and you're pulling back the scope. Okay? Hilum of the spleen. Fantastic. Now let's do the opposite. So we're going ahead. Take care. Good. Good. Excellent. Excellent. Drop your hand down. Drop your hand down. Fantastic. You see that? That is the pancreatic duct falling down. Okay, so you've done a very good exam. Now usually when you're here and you're seeing the pancreatic duct falling, you push your scope in about a centimeter so that you can evaluate this area of the pancreas. Okay, that is the torus area of the pancreas that usually you will miss a cancer at in this examination. So now you've got a beautiful view of your pancreas. We are all happy there is nothing there. So let's give a little bit of air in the lumen. Air in the lumen. Tero, give air, see exactly where you need to go. Lift your hand up. Now push it. Good. Again, hold on one second. Remember, if you are seeing where you are going, you're not doing it right? So if you push here, your transducer is going down. So you need to put whatever it is that you want to, with the area you want to go, out of view, all the way down, and then slowly introduce your scope. There you go. Now go big wheel up slightly. Slightly. Fantastic. There you are. So you're in the bulb of the duodenum, right? So let's hold on. So give a little bit of air. Okay. Big wheel up so you can see where you are. And now the apex. Can you with your right hand point to the apex of the duodenum? Excellent. So that's where you want to go. So put your transducer on that apex. Okay? Put your transducer on the apex and suction down. Excellent. Okay? Now let's look at the ultrasound image and see if that is helping us any. Okay? So we need to identify some structure over here that will help us. There you go. Hold on. Some structure over here that will help us orient ourselves. Okay? So you did great. You are right at the ampulla. Okay? Now let me come this side. And I'm going to put a cursor for you. Okay? That is your bile duct. That is your pancreatic duct. Hold on, don't move. Go back the other way. So this hand goes down a little. Down a little, nice. So you see this dark area that is coming down? This dark area here.
Which one?
Okay, so suction. You need to suction and you push the scope in a little so you can see better. This dark area. You see a line between these two? And if I were to sort of extrapolate that line and go up, you'll see it extends all the way here.
Yes.
So this is the duodenal muscularis propria. Okay? So where these two ducts meet that duodenal muscularis propria, that is your ampullary complex. Okay? That is where you know I need to stop evaluating and I can stop there. Now if we were to at this point inject water into your scope, this area would expand out. So here is your collapsed duodenum right here. Okay? So the thing you need to look for is you need to look for this line, okay, to determine where to stop evaluating your bile duct. So bile duct, pancreatic duct, black line. MP, muscularis propria. ये वाला, ये जो काला सा line है, okay, you need to squint your eyes just a little. And one thing that I keep emphasizing is that EOS is not a static exam. You cannot look at one image and try to interpret it. You have to put a sway in your hand, a little bit of a sway. If you keep doing this, you're going to be able to render in 3 dimension the 2D image that you are seeing. Okay, now you can see that black line a little better. Now, okay. So now let's keep, so what we want to do is we want to have this under your transducer.
Okay.
Now there is no right and wrong way to do this. You need to figure it out. Okay, so how do you put this thing over here? So try baby movements. Big wheel up a little bit, see if that is working for you. Okay, big wheel up, beautiful, that is working for you, right? Now don't let your scope fall back because air is seeping in there. So suction a little bit, suction, big wheel up karo. No, big wheel up, the other way around. Nice. More, put it more up. Big wheel up, excellent. Okay, so that is your bile duct. Now, the question is, we're looking at a tubular structure, right? And one second. We're looking at a tubular structure and you're wondering in your head, is this a vein? Is it an artery? Is it a duct? The answer is usually very quick. Just throw a Doppler on and you will figure out what that is. Okay? The difference between a round black structure that is poor on Doppler, meaning you are throwing a Doppler on, it is not lighting up, and now you're questioning, is that a cyst, a round cyst, or is it a duct? The answer to that is an easy one. You just track it. If you're able to track it by turning your scope like this up and down, then it is a duct, it is a tube, right? If it is a cyst, it will collapse and open up again. So it sort of winks at you. Okay? So now here we are, and you are, without pressing too much, you're turning here and big wheel up karo, big wheel up. Up, 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 up. Excellent. So there you are. So hold on one second. This is a beautiful image, okay? This is your gallbladder right here. This is the neck of your gallbladder that has a stone inside it. This here is your common hepatic duct that just crossed around. So you did a very good job at following. There you go. You see? That is your common bile duct.
Where is the common?
This.
Okay.
So this is your common bile duct. You are tracking it up to the hilum of the liver. So you are doing left. And in this case, what is happening is the gallbladder, this is the neck of the gallbladder and the origin of the cystic duct. That is sort of overlaying this. It doesn't usually happen like this. This is an aberrancy. But that is what you're seeing. So the question is, are we making this up or is it real? Always question yourself and throw on a Doppler. Okay, there you are. So you see, these are all ductal structures.
Right.
Now you want to figure out what is in there, and that is a stone. Okay, right here. Huh? So that is a stone there. Okay, it's these stones that are problematic. You see the size of it? It is small, and these type of stones can fall into the common bile duct. A big stone typically will not do that. Okay, this is what causes cholecystitis and all of that. So you've seen, you went to your common hepatic duct, you kind of looked right here is where your common hepatic is branching out into the right and the left main hepatic. So you have been able to track this from the ampulla all the way up to the liver and see its bifurcation. So fantastic. Okay. Now let us look at this gallbladder. Okay. So big wheel up a little bit, upper, big wheel up karo.
Maximum.
Yeah, all the way up. Okay.
Yes.
So then let's figure out what else to do here. Okay, so if you're maximally up on the big wheel, let's torque your scope to the right a little. That is not giving us a view. Okay, so let's try this. Let's move the other side and pull back our scope. So what's happening is, I want you to notice what's happening. The gallbladder is here, but you are collapsing it because this transducer is pressing the gallbladder.
Right.
So what you want to do is don't push down and pull back instead. Pull back, big wheel up karo, big wheel up, up. Is your big wheel up?
Yes, maximum.
Maximum, huh? So we are getting a view of the gallbladder, but it is not the best view. So what we are doing is, we are right torquing our scope and we are coming back. Now stay there, hold on. Now the question is it only one stone that she has or more stones? So what you want to do is, once you are in the fundus of your gallbladder, hold this position and then have somebody, maybe your assistant, agitate the gallbladder. So what we are going to do is, in the right upper quadrant, we're going to press that gallbladder a little bit and see if there is anything else that jumps up in there. So this maneuver is very good for sludge. If you're questioning dependent sludge versus something like adenomyosis, you know, which is a sort of thickening. You fell back. Okay, no problem. Go back in now. Go back in. Go back in. Excellent. Okay, so now let's hang on here. Clean your lens. Give some air. Clean your lens. Clean it. थोड़ा और clean. नहीं, you're inflating the balloon. So suction down. Suction down. वो suction वाला full press करो all the way down. नहीं हो रहा. अच्छा, maybe a suction button problem, Henry. Do we have another suction button? Just let him take it out 1 second. Press, press, press. Excellent. हो गया. Fine. So now give some air. Take a stop. So don't push your scope without knowing where the lumen is. Take a. So big wheel up a little bit. All many movements. Excellent. So now you know where the apex is. You know where the duodenum is, right? So angle your scope in a way that is going to be safe. मतलब इसको ऐसे उठाओ, okay? And you put that lumen of the duodenum out of view. Don't suction. Put the lumen has to be out of view, because only when it is out of view is your transducer truly straight and going down. Right. So now you introduce it in. Excellent. And there should be no resistance here. Okay? This should be a very simple, gentle insertion. Excellent. Right there. Stop. So you stop. So you've come to an area where you think the ampulla is. Okay? So that is comfortable. Now, small wheel all the way to the right, karo. All the way to the right. Okay. You can choose to lock it. I would recommend you don't. Use your thumb. Now hold the scope and आगे से पकड़ो इसको. And we're going to do this together. Right torque and pull back. Excellent. So right here, stop. Now I'll point out one more thing. Okay, as you are pulling back, show me the scope. I'll show you this. So just focus on the lumen of the duodenum. Okay. If while you are going down, okay, the lumen is round, that means you are not doing anything to deform it. That means there is no problem. But if you see a situation like this, where the lumen is oblong, it is like an egg, it is ovular, that means you are putting a lot of pressure on the duodenum, and you should not do that. Okay? So pay attention to the configuration of the duodenum as you are working. Okay? तो यहाँ पे आ जाओ, come, and let us do that. तो right torque करो इसको, and show me the ampulla. Let's see the ampulla here. संभाल के, you see what's happening? You're getting a little bit, so your transducer is going there when your duodenum is there. So if this happens, you need to fix it. So it's happening because our wheel is in the wrong direction. There we go. Now it's all the way down. And you can introduce your scope in comfortably. Is your wheel all the way down? Okay. Okay, let's do that one more time. So come out all the way. Come out. Take care. Come out. No problem. You're fine. Come out all the way. Sambal ke. Let go of all your wheels. Okay. And let us re-intubate it. Go in. It has to be out of view. View se isko nikal do. Excellent. Now enter in, stop, find out where your lumen is. Okay? Every time always make it a habit to look for that lumen where it is, so that you know where you are pushing. Now put it out of view, the other way, and many movements on the dials. Okay? Not fast movements. That will sort of make your examination a little more sort of refined. Okay? So now you are here, and you are slowly going to introduce your scope in. Fantastic. Okay, here. Now, small wheel to the right all the way. Guma do usko. Small wheel to the right all the way. Okay. Now hold it and don't be shy when you're reducing. Just pay attention to the lumen. That's key. Excellent. Okay, stop. You're fine. Okay? No, you're good. This is good. Okay, so now stabilize. Get yourself comfortable. You're in a good position. Manipulate your wheels to figure out what. Manipulate your wheels, karo. Okay, get yourself in the center like you would for an ERCP. Okay. Okay, and let us try to visually see if we can see the ampulla. Okay, that is the best way to do this. If you can visually see the ampulla, पीछे आ जाओ, पीछे आ जाओ, थोड़ा आहिस्ता. So we're coming very gently and slowly. You want, there you go. See that? So this helps you with two things. Okay, when you're evaluating bile duct problems or pancreatic duct problems, you are obligated to get a view of the ampulla. This must happen. Okay, so you must make sure that there is no tumor there that is resulting in a dilatation in both the ducts, that there is no abnormality that needs to be worked out. You are seeing the ampulla, it looks normal. So that's good. ऐसे कर दो अभी इसको. Now you go, you want to raise your transducer up to touch that ampulla. Okay, and the way to raise the transducer up is to put your big wheel down. Stop. Now, when you do that, usually your transducer is about a centimeter or so under what you are seeing on your vision, right? So normally you want to pull back just a little. In this case, this is the area you are focusing on, yahan pe. Okay, and I can tell you, you've done really well because we are already seeing this tube here, and this is your pancreatic duct. Okay, on top of it will be your bile duct, but the job is not done. Okay, so the most common place that you will miss a cancer is not here, it is here. Okay, your big wheel, you need to be a little relaxed. Remember, big wheel motion is only to see, it is not to press. Okay, so if that is less. So suction down, excellent. So use suction, use whatever you can to maintain coupling. Okay, so here we are, you're seeing some type of a blood vessel. You know, is it the IVC, is it the aorta? You can tell usually whether it's compressible or not. But what we are focusing on is this part here. Okay, two ductal structures. But when you pull your scope back, यहाँ पे, you need to turn left, until you come to the cardinal vessels. Okay, that there is the right kidney. We are far out. That's fine. We go left a little bit, there we go. So ये वाली exam, आप spend your time right here. This is Uncinate process. Okay, these two vessels, until you see these vessels, Terja, hold your scope. Until you see these two vessels here, this is a vein, this is the artery. Until you see these two, your examination of the Uncinate is incomplete. Okay? So yeah, you must see those two vessels. So once again, you find your ampullary complex, and wahan se you have to go left and you have to go right until you have fully examined this area, and then you can go back. Okay? So here we are.
Where's the ampullary complex?
Right here. This. Okay? So you just need to suction a little bit. Suction karo. And go move your big wheel down a little bit. Thoda sa down. Okay, and we are going to pull back. Okay, right here. So the question to us was, what does this patient have and why does she have a dilated CBD? So we need to answer that question. Okay, is it a stricture? Is it a stone? And so let's look at this area. Interestingly, she may have a stone. Okay, good. So I want to just orient you. Okay, these are the structures we are targeting. So focus your exam there. Pull your scope back just a tether. Pull it back. Okay. Now that thing that came up there, that is what I'm trying to look at. Can you look at it again? Go the other way. Right there. This. Okay, this area. Now let's see, there is something that is in the duct. I don't know what that is, but it looks like it may be casting a shadow there. Okay? So whatever this is, we need to evaluate it better, right? So can we have a little yet thoda pani milega to push through the scope? A little bit of water. So this looks to me like it is a filling defect down here. Okay? And okay, so now what we do is we're going to do the opposite of what you normally would do, right? We normally would suction, but now you need to get off the suction, okay? And we'll need some more water as well, okay? So I'm going to push water in You need to be off the suction, more water.
200 is what?
It doesn't matter. The key is that she's not intubated, okay? And you want to do everything possible to avoid an aspiration. Duodenum is generally safe to sort of lavage with water, but if you want to get a good look at the ampulla, this is usually the only way to do it. Like Dr. Tayyab was just showing on that exam. और पानी जल्दी से निकालो तो क्या ये so what will happen is the water will quickly transition down, and so you want to be somewhat quick in the way you evaluate it. ठीक है, थोड़ा और पानी यहाँ पे डाल दो जल्दी से, push it in, डाल दो, go, पानी, excellent. So now, does this make more sense, Abhi? You know, we keep talking about a collapsed duodenum and that's it. And this is the MP of the duodenum, right?
Right.
This is all pancreas. So show me the ducts that you showed me a minute ago. Where are the ducts? दूसरी side. Oh, okay, right there. Okay. So now we are trying to figure out if this patient has an impacted stone in her bile duct or not. So big wheel down a little bit, big wheel को नीचे कर दो. Okay, nice. So right there, hold the scope carefully,
Yes,
fix the
yes.
scope.
Yes, fixed.
Okay, so right here is the common bile duct, right? And we need to look at the bottom of it to see वहाँ पे कुछ है. So focus on that part, right there. यहाँ पे दिख रही है आपको? Okay, so there very easily could be something in her bile duct, right? So big wheel down a little bit, big wheel को नीचे करो. Okay, so yeah, right there. Right, so right there, do you see it?
Yes.
This is the, no, go the other way, you were right there a second ago. Ulta, the other way. So, yeah, it's a tough one actually. We're not seeing a clear-cut stone, but I would favor something like sludge. Wait, does she have abnormal LFTs, guys?
Yes, sir.
She does, huh?
Recent LFTs
Are normal. Okay. Can I just take one quick look and we'll get done? Okay, so here we are and we're looking at the bile duct. Oh, CT is suggesting debris in the lower CBD. Yeah, you know, I want to say that she probably does have some amount of stuff right here. Okay, so I agree actually. The question is, you know, does this warrant an ERCP or not? So the answer usually lies in what it is doing to the rest of the common bile duct. Now this part of it is the intrapancreatic common bile duct, and you don't expect that to be very dilated one way or another. But we're going to slowly track that back towards the liver. Take care, we're coming back towards the liver. This is still the duct and we are just comfortably pulling back from the duodenum. That's the hilum. Interesting. So she's not consented for ERCP.
The first plan was to do an ERCP.
And then decide? Okay. So I'm just going to quickly empty her stomach out. Yeah, I think we favor a stone. We're going to tell you in a second if we think it is obstructive or not. No cholangitis, no white count, no fever, no? Okay, good. So, well, I think most importantly we've answered the question of whether or not she has a tumor. Okay, so this is her common bile duct. We're looking at it here. Okay, we're going to track it down. Again, I am compressing it despite sort of consciously trying not to do that. And that there is her ampulla. Okay? Right there, yeah. So right there is the ampullary complex, and yeah, she does have a little bit of something in the lower end of the common bile duct, right there. Okay, there's a little sludge. I mean, it's not impressive,
So,
but there is something right there that's
Kambi?
gunking around.
Hi. Just wanted to know, are the LFTs abnormal?
They're normal right now, but if I understand correctly, they have been abnormal in the past. So the question was ductal dilatation, Dr. Niaz, and whether it was a stricture or a stone or a tumor. So I think effectively we've ruled out a tumor. There's no abnormal thickening in the walls of the common bile duct as it approaches the ampulla. There's nothing there to suggest extrinsic compression. So I think we're fairly safe saying there's no tumor. As for a stricture, there's nothing in the rest of the pancreas that would cause a secondary stricture. We're not seeing changes in the bile duct wall itself that would suggest fibrosis and sort of a stricture from chronic choledocholithiasis either. And there's a little bit of sludge in the lower end of the common bile duct that does not appear to be obstructive. Her CBD measures about 7-ish millimeters in its largest dimension. And for somebody who's, how old is she? 60 something? 65. I'd probably place that at the upper end of normal. So I think it would be fair to monitor her LFTs at this point and see how she does. But the one thing we would recommend is a cholecystectomy. I mean, she is having some abdominal pain and she does have a stone in her gallbladder, but those were our thoughts. Would you agree?
Mostly yes, but I was just thinking whether with the sludge in the distal end and history of abnormalities of LFTs and gallbladder stone, would it be unjustified if one was to go ahead and do an ERCP in this patient would be my question. In our part of the world, the consent is given by the family. This is what we were discussing. Once we've done this, we could actually go and ask the family and explain to them if they wish, then we could actually put a camera, could change the scope, go up and see what's going on in the CBD. Sludge is can and cannot be worrying, because I mean, you know, with the pancreatitis risk, you're obviously concerned. On the other hand, if the LFTs were abnormal and they have now become normal, it's telling you that she's obviously passed something. So I don't know. What do you think, Father?
No, I'd agree, Dr. Niaz. She's had some intermittent LFT abnormalities. I had some abdominal pain, but it's not the relentless pain that suddenly improved to suggest a past stone. It would not be unreasonable at all to do an ERCP in this case. Personally, if she had consented for an ERCP, and usually in that part of the world, it means stopping the procedure, waiting a day or two, and then reconsenting the patient, in which case I may have erred on the side of not doing the procedure and monitoring her. But if it means the same anesthetic and getting consent from family, I think that's an easy one.
If she is asymptomatic and
Can we सुनाई नहीं दे रहा है वहाँ पे? I cannot. Can we increase the volume on the? Sorry, Dr. Niaz.
There were some debris at the lower end.
Some sludge.
Yeah,
in
I
the
think
lower
so
end of the
too.
bile. So are they still with us, or have they moved to another room?
No, we are finished.
Oh, where's the last room? Okay. Did someone have a question then? No.
Not to us.
Okay.
So consensus here is that we should leave it. Kambi,
Yes, Dr. Nias.
the consensus here is that we should leave it, refer her for lap chole, and if she has a problem, then repeat an ERC, do an ERCP if necessary.
If necessary.
I may be in the minority, but I don't agree with that. I would have actually done an ERCP.
Would have done an ERCP. Dr.
I
Nias,
would have, but I'm not saying I'm right. This is what because my concern is obviously with the debris there and history of this alteration of LFTs. I'm concerned about acute pancreatitis.
It's a valid point either way, Dr. Nias, particularly since she has a stone that's in the cystic duct that is a size that could very easily pass down into the common bile duct. So, you know, if it's somebody that is sort of going to follow up and reliable with that, I think it's fair to say, you know, just to get the gallbladder removed, since it's a non-obstructive stone, no cholangitis, we're fairly good with that. On the other hand, you know, if there's any question for follow-up and we won't have to reconsent her, I think it's very reasonable to do an ERCP also. So I guess it's quite conditional. That's what I would base my decision on.
Yeah. I think ERCP itself in cause of pancreatitis should be a conservative, especially in young female patients. More conservative. Either of those would be fine, but I personally would send patient to cholecystectomy, and if